It starts as a sharp, piercing pain in your upper abdomen that feels like it's cutting straight through your back. Within hours, your body can spiral into a state of total crisis. This is acute pancreatitis, a condition where your own biology turns against itself. To understand why this happens, think of the pancreas as an enzyme factory. It produces powerful digestive enzymes, including lipase, which breaks down fats, amylase, which breaks down carbohydrates, and proteases, such as a trypsin, which break down proteins. Under normal circumstances, these enzymes remain inactive while inside the pancreas and are only activated once they reach the small intestine, where they safely digest the food you eat. In acute pancreatitis, that safety mechanism fails. The enzymes become activated too early while they are still inside the pancreas. And instead of digesting food, they begin digesting the pancreas itself, a process known as autodigestion. This triggers intense inflammation, swelling, and in severe cases, tissue necrosis. If the inflammatory response becomes widespread, it can progress to sepsis, multi organ failure, and even death. What actually triggers this process? This is the etiology, the why behind the crisis. While there are many potential triggers, the two most common causes are gallstones and alcohol. Gallstones are a leading cause. A stone travels out of the gallbladder and becomes stuck in the ampulla of Vater. And this is where the common bile duct and pancreatic duct join to drain bile and pancreatic juices into the duodenum. When a stone blocks this flow, bile backs up into the pancreas, which triggers digestive enzymes to activate inside the organ itself. Alcohol is the other primary cause, which acts as a direct toxin to the pancreatic cells, causing the small ducts to become obstructed and trapping those dangerous enzymes inside the tissue. However, if those aren't the cause, we have to look for other triggers. We check for high levels of triglycerides and high levels of calcium, which can also lead to enzyme activation. Also, some medications or trauma can also lead to enzyme activation. And in very rare cases, even something as unexpected as a scorpion's sting can trigger the entire process. The way a patient actually feels when this process starts is unmistakable. They typically present with sudden severe pain in the upper abdomen, usually in the epigastric region, and then the pain often radiates to the back because the pancreas lies deep within the abdomen, close to the posterior abdominal wall. Nausea and vomiting are also common, and some patients find that the pain improves slightly when sitting forward. On examination, the patient may appear visibly unwell. Findings can include tachycardia, sweating, shallow breathing, abdominal tenderness and distension, as well as reduced bowel sounds due to temporary paralysis of the intestine known as ileus. These changes result from pain, inflammation, and fluid shifting out of the circulation. Jaundice may suggest gallstone pancreatitis, particularly when a gallstone is obstructing the common bile duct. In severe cases, the inflammation can extend beyond the pancreas. Colonsine, which is bruising around the umbilicus, and gray ternocine, which is bruising over the flanks, are rare findings associated with retroperitoneal bleeding and severe pancreatitis. Fever and leukocytosis may occur as part of the inflammatory response. However, persistent deterioration, sepsis, or worsening after initial improvement may suggest infected pancreatic necrosis or uninfected fluid collection. Severe pancreatitis can also trigger widespread systemic inflammation, potentially leading to shock, respiratory failure, acute kidney injury, and multi organ failure. Now that we know how acute pancreatitis present in a patient, how do we actually prove it? To make an official diagnosis, we look at three specific criteria. Acute pancreatitis is diagnosed when at least two of three features are present. These include typical persistent epigastric pain, often radiating to the back, serum lipase or amylase at least three times the upper limit of normal, or characteristic findings of acute pancreatitis on imaging, usually CT or MRI. When the pain and enzymes level are typical, imaging is not always needed to confirm the diagnosis. Once acute pancreatitis has been diagnosed, additional blood tests are used to identify the underlying cause and assess the patient's condition. These commonly include the white blood cell count, hematocrit, blood urea nitrogen, creatinine, glucose, calcium, electrolytes, and liver function tests. An elevated ALT or bilirubin may suggest gallstone pancreatitis or obstruction of the common bile duct. Serum triglycerides should also be measured when gallstones and alcohol are not an obvious cause. In severely unwell patients, lactate may be checked as an elevated level can indicate impaired tissue perfusion. And imaging depends on the clinical situation. Abdominal ultrasound is mainly used to detect gallstones and dilation of the bile ducts. Contrast enhanced CT is not routinely required when the diagnosis is already clear. It is generally reserved for cases in which the diagnosis remains uncertain or when the patient deteriorates or fails to improve after approximately 48 to 72 hours. CT can help identify complications such as pancreatic necrosis and fluid collections. MRCP is a non-invasive MRI technique used to examine the bile ducts and pancreatic duct, particularly when a biliary obstruction is suspected but ultrasound findings are inconclusive. ERCP, in contrast, is an invasive endoscopic procedure that can remove an obstructing stone and restore bile flow. It's mainly used when gallstone pancreatitis is complicated by cholangitis or persistent biliary obstruction. After identifying the possible cause and complications, acute pancreatitis can also be classified according to its morphology and severity. Acute pancreatitis can be divided morphologically into two main types: interstitial edematous pancreatitis and necrotizing pancreatitis. The first one, interstitial edematous pancreatitis, is the more common type. The pancreas become inflamed and swollen, but the pancreatic tissue remains viable. Imaging may show enlargement of the pancreas and inflammatory changes in the surrounding fat, known as peripancreatic stranding. Most cases follow a relatively mild and self-limiting course. The other type is called necrotizing pancreatitis, which is less common but more serious. In this form, areas of the pancreas, the surrounding tissue, or both lose their viability and undergo necrosis, which means tissue death. This type is associated with a longer disease course and a greater risk of complications, particularly if the necrotic tissue becomes infected. In addition to its morphological type, acute pancreatitis is classified according to the presence and duration of organ failure. Acute pancreatitis is classified by severity as mild, moderate severe, or severe. Mild acute pancreatitis causes no organ failure and no local or systemic complications. Moderately severe pancreatitis involves local or systemic complications or transient organ failure that resolves within 48 hours. Severe acute pancreatitis is defined by persistent organ failure lasting longer than 48 hours, which may involve one or several organ systems. Organ failure can be assessed using the modified Marshall score. This evaluates the three systems: respiratory function through oxygenation, cardiovascular function through blood pressure and its response to treatment, and renal function through serum creatinine. Score of two or more in any of these systems indicates organ failure. In simple terms, worsening oxygenation, persistent hypotension, or rising creatinine suggests more severe organ dysfunction and a greater need for close monitoring and intensive support. Treatment of acute pancreatitis is mainly supportive, meaning that the patient is supported while the pancreatic inflammation settles. The first step is usually intravenous fluid therapy, where fluids are given directly into a vein to maintain circulation and prevent dehydration. During this time, fluid intake, urine output, and vital signs are monitored closely to make sure the patient is receiving enough fluid without becoming overloaded. At the same time, adequate pain relief is essential. Severe pain may require opioids such as fentanyl or hydromorphone. Nutrition is another important part of the treatment. Patients should begin eating orally as soon as they can tolerate it. If this is not possible, enteral feeding may be used, meaning that liquid nutrition is delivered through a tube into the stomach or small intestine. Most patients can be managed on a regular hospital ward. However, those with severe pancreatitis, unstable vital signs, or organ failure may require admission to the intensive care unit. Antibiotics, they are not routinely given because acute pancreatitis is usually an inflammation rather than a bacterial infection. They are only used if pancreatic necrosis become infected, meaning that areas of dead pancreatic tissue develop an infection, or if there is another infection elsewhere in the body. Pancreatic necrosis itself does not always require an intervention. If treatment becomes necessary, the necrotic collection may first be drained. Another option is called necrosectomy, which means removing dead pancreatic tissue. It's usually delayed for approximately 4 weeks when the patient's condition better. And finally, urgent ERCP may be required when gallstone pancreatitis is accompanied by cholangitis, which is an infection of the bile ducts. Pancreatitis is a reminder of how delicate the balance of our digestive system is. While most cases are mild and resolve with supportive care, the potential for rapid progression into systemic illness is why early diagnosis and careful monitoring are so critical. If you found this breakdown helpful, consider subscribing to medwithmead for more deep dives into clinical medicine, and I'll see you in the next one. Thank you.